So, John, over to you.
Hello, thank you for the very kind invitation, and many thanks to Dipti for the very insightful first commentary on this topic. I'm not sure I can match that, but I'll do my best. To start with a disclosure, I have no conflicts of interest. I have no personal Facebook, Twitter, or other social media accounts. I have not signed any petitions, declarations, memoranda, advocacy statements for zero COVID, against zero COVID, Great Barrington, Jon Snow. These have been signed by amazing scientists and great colleagues and wonderful friends, but I haven't done that. Some preemptive comments. I love zero COVID in the same way as I love zero cancer, zero tuberculosis, zero starvation, zero any disease. The question is, can we achieve this? Will efforts to achieve it reduce or increase SARS-CoV-2 deaths as well as overall deaths and the burden of total, not just SARS-CoV-2 related disease? And aside, how many other diseases have we managed to eradicate entirely? Tuberculosis, malaria, syphilis, and yaws. We have tried with all of those diseases with animal reservoir and with many subclinical infections. We must be kidding. Now, if zero COVID is near zero, I'm 100% in agreement with Dipti, but we have to define exactly what we mean by near, because near has quite some range. Is zero COVID, no matter how we want to define it, is it up to us or is it up to the virus? And I'm not talking about New Zealand, I'm not talking about Vietnam, I'm not talking about Taiwan, that did a wonderful job and did exactly what I was saying a year ago. Test, 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 that's what the WHO was saying, and then isolate and contact trace. But now the horses are out of the barn. Is it up to us where the SARS-CoV-2 will become, actually already is endemic, and what its severity and total burden will be in future seasons in countries where it has become endemic? Why am I saying this? Well, we have 120 million documented cases globally and about 2.6 million deaths. This is horrible, completely horrible. This is 0.033% of the global population, but approximately 2 billion total infections have happened. We have about 20 to 25% of the global population that has already been infected. Perhaps 2 to 3% has been infected twice during 2019 to 2021. The global infection fatality rate, if you average out across the world, is about 0.15%. It's much higher in Americas and Europe. It's much lower in Asia and Africa. It has substantial variability across locations, populations, and settings. I'm sorry for the UK. You have really done very poorly. You have among the highest IFRs in the world. Approximately 1% of the global population has been fully vaccinated, and approximately another 2% has received one vaccine dose. We need more of that. We're pushing for that, but it will take a while, but hopefully we will get to much higher levels. Most people agree that coronavirus SARS-CoV-2 will become endemic, and actually probably has become endemic to a large extent to many countries. And we really don't know much about the future. There's uncertainty about immune escape, about the extent of waning immunity, about uneven vaccine distribution, about vaccine hesitancy that creates a problem, about the lack of political will, about animal reservoirs, and many, many other reasons that create uncertainty. But if you look at that paper in Science, it says SARS-CoV-2 may be no more virulent than the common cold eventually, once we reach the endemic phase. We predict a very different outcome, And could we really reach a point where we wish that next year, the season will be one with predominantly SARS-CoV-2 rather than with influenza? It sounds crazy. Ideally, of course, we want nobody to be infected. I would not wish to have that virus spread widely in the community, by no means. However, if they are infected, 40 to 70% of the global population would do better if infected with influenza than with SARS-CoV-2. With better treatments, this percentage may rise to 60 to 80%. If the remaining 20 to 40% can be largely effectively shielded with vaccination and or other means, the IFR or SARS-CoV-2 may become far lower than the IFR of influenza. And in this case, might we even celebrate if a given year has a preponderance of SARS-CoV-2 than influenza infections? Is that science fiction? Well, let's take a look on why did we lose all these people to SARS-CoV-2, to COVID-19? What are the modifiable causes behind that hecatomb? Can we modulate them towards zero COVID? If we eradicate them, we eradicate also COVID-19 deaths. If we reduce them, we reduce also COVID-19 deaths. We should be aware of uncertainty about attributable fractions, of course, but we do know the main culprits. Their impact is cumulative, additive, and in some cases, probably multiplicative. And this may be good news. We don't need to succeed in all fronts. Major success in some of these fronts may have a major impact. What really caused these 2.6 million deaths is social injustice, inequalities, racism, poverty, smoking, other modifiable risk factors in lifestyle, for example, obesity, poor protection of nursing homes, poor adoption of effective public health measures, adoption of harmful pro-contagion public health measures, for example, totally foolish blind lockdowns, suboptimal and harmful treatments and medical care, and of course, lack of vaccination until recently. How many people were involved for each of those? These are rough estimates. Each of these factors affected, of course, not alone, many, many people, hundreds of thousands, sometimes millions of deaths were involved in this. Here's one example. Many people took hydroxychloroquine in high doses for treatment when they were very, very sick. The meta-analysis that will be coming out that we've done in international consortium shows about a 10% increase in the risk of death. It's if 1 million people who died got hydroxychloroquine, then we have about 100,000 deaths from misuse hydroxychloroquine in that population. We know who are the people at risk. We protect them specifically. You have some example here that I'm trying to make. You have some serial killer who states his intention to kill someone. I'm going to kill people in nursing homes. I'm going to kill people who have this type of features. What do? A, you send 5 well-trained policemen to protect that person. B, you tell all 3 million people in the city to stay at home forever. C, you send 5,000 policemen to patrol random locations in the city. D, you make a sermon or a tutorial on how love should conquer hate. That's probably an easy answer to C, because we have very good risk stratification. We know who is at risk. We know that it's a very small percentage of people who are at tremendous risk, with like 25% risk of dying, IFR of 25%. We know there's many others who are at high IFR, and we know that there are many, many others who are at very, very low risk. So precision medicine, precision health, it was a buzzword. It was the future of medicine just before COVID. We were trying to achieve that with relative risks of 1.3 or even 1.03, for example, in genetics and genomics. We were spending tens of billions of dollars. We were sure that we will make it. And now we are saying that we cannot achieve precision shielding with COVID-19, even though we have relative risks of more than 1,000, sometimes risk ratios of 7,000 if you compare an 80-year-old who's frail against a child. So are we going to achieve effective shielding or inverse protection? We have examples that we have achieved either or the other. Singapore, a city-state with very high population density, about 60,000 documented cases, probably more than 100,000 cases, just 29 deaths, only 3 nursing homes, infection fatality less than 0.03%, probably less than 0.02%. Converse example, first wave in Spain, Belgium, and the UK, 63%, 61%, 44% of COVID-19 deaths were in nursing home residents. Nursing home residents had 2 to 3 times, perhaps even higher risk of infection than other people. And given these massacres, infection fatality rate reached or exceeded 1% in these locations in the first wave. We can do much better. For example, in nursing homes, in the second wave, we have done much better. We see a much lower morbidity and mortality in nursing homes in the second wave, and we can do much, much better, hopefully in the future, with vaccination being on board. Risk factors, tobacco. Tobacco is going to kill 1 billion people in the next century, and it's happening right now, and it is in the background of the majority of people who die with COVID-19. So could SARS-CoV-2 be a covert blessing, helping to save up to 1 billion deaths over the next century? Along with Prabhat Jha from the University of Toronto, I wrote this paper arguing we have destroyed our entire world trying to get rid of COVID. We haven't really been very successful so far. Why don't we just do far less, but eliminate the tobacco industry? And that will really gain us hundreds of millions of deaths. We're dealing with an invisible enemy. This means that often we have taken blind measures, and unfortunately, most of these blind measures do not work. This is a paper we published 2 months ago. We saw that restrictive measures work, but you don't have to be more restrictive. You can be targeted, you can be focused, and still work. More restrictive lockdown actually tends to increase caseload, and I can discuss about that if we have time afterwards. Which interventions work best? If you go with just SIR modeling, different models give different inferences. We have a paper that will be coming out in Journal of Clinical Epidemiology. We use 2 models developed by a brilliant team at Imperial College. The one that they published in Nature shows that lockdowns work, amazingly so. The other model that they developed shows that they do not work at all. We have the problem of not causing harm. We should not cause harm. We have tremendous potential of causing harm if we don't use the proper measures, the targeted measures. measured measures. And I'm not going to go through that list because it's really very, very depressing, but we're talking about posing billions of lives at stake if we don't do it right. Can we predict what will happen? I cannot predict. If you can predict, I'm very happy, please let me know. But forecasting throughout this pandemic has failed. We have many unknowns. We have many factors. Vaccines are an amazing development, but we don't know how quickly, how successfully we can deploy them to a large segment of the population. Treatments are evolving, economic, social disruption, other public health measures, interplay with other diseases, chronic disease, catastrophic, chaotic events as people get just thinking about wars and riots and revolutions if we continue with this nonsense. Will it come back? It may. We have reinfections, but so far the evidence suggests that reinfections are not so horrible. We published these data from the national database in Austria, odds ratio 0.09 in the next season, and none of those led to a COVID-19 death. Do we know everything? We know very little still. We know far more than when we started, but there's still disagreement on important topics. And Dipti may be right. And I'm willing to go for a near zero, depending on what near means. But if we don't know, I would argue we're 1.5 years almost into this since it started, and it's going to take much longer. We need randomized evidence. We need the best evidence. A randomized trial is worth a million tweets. And I hope we will all agree, and I'm closing with this, I'm not sure about zero COVID, whether it can be done. Hopefully it can be done. Hopefully the virus will do us the favor, but zero life is not an option for trying without evidence and unsuccessfully to save lives. And here I need to disclose some of my real conflicts. I love fencing, and I would like to go back to doing this. And I write libretti for opera. And I hated it when the world premiere of my opera could not be staged in November, but hopefully you can see it online on the web. Can we save lives? Can we save our life? Can we have zero COVID? Can we have zero nonsense? Thank you.
Thanks very much, John. So we've had two really excellent overviews of the different arguments, or some of the different arguments to come up with here. But in the interests of the workshop as a whole, I am going to hand back to Phil because we are just actually on time almost.